Hi there, this is Dr. Bhomik, and today I'm going to do things a little bit different. You have heard all the lectures, but there are many more to come. But I thought that we give a little break. We discuss about 25 board review questions related to the pediatric endocrinology. And after that, we will again go through the lecture series, and I plan to discuss many more endocrine related pediatric board questions, and many of them I submitted to the American Board of Pediatrics when I was not retired working in South Alabama, and many of them were accepted, and so this will be what we really see most of the time. Okay, so we'll start with the first question. Is the genital examination of a newborn child reveals a phallus that, when stressed, measure 1.5 centimeter length, and this baby has presence of testicle on the both side and the scrotum, and with this finding, what would be the most likely explanation for this finding? Is it a normal genitalia of a normal male infant? Is it male with congenital adrenal hyperplasia? Or is it really a female with congenital adrenal hyperplasia? Or it is a gonad that did not differentiate into the testicle? Or is it hypopituitarism? Okay, let's take the first one. This is certainly not a normal genitalia. If you have listened to my lectures when we discuss about the puberty and initiation of puberty, I told you the size of the phallus in an average in full-term newborn is 2.5 centimeter. So 1.5 centimeter is not adequate size. It's less than 2 centimeter. Is considered a small phallus. 1.5 centimeter falls in the category of microphallus. Is it a male with congenital adrenal hyperplasia? Male with congenital adrenal hyperplasia should not have small phallus. The phallus size is normal, and that one of the problem with these CAAs in male infant, that their phallus is normal, and therefore this does not fit the second statement either. Is it a female with congenital adrenal hyperplasia? This is not a female baby because the question said there is testicle on the both side. A gonad did not differentiate into testes. That's not true. Could it be hypopituitarism? More than likely, this patient have hypopituitarism, but hypopituitarism usually present with a small phallus or microphallus with hypoglycemia. Remember the hypoglycemia? And many of them may have congenital growth hormone deficiency, and they present with septo-optic dysplasia. That means you will see the strabismus and horizontal nystagmus. So this is more likely is hypopituitarism. Let's go to the second question. The recognized cause of a height below third percentile in a 10-year-old child include all of the following except: could it be Crohn's disease, congenital adrenal hyperplasia, 45X karyotype, Turner syndrome, constitutional delay of growth, and genetic short stature. Crohn's disease associated with growth failure and malnutrition is well known. So it could be Crohn's disease. Congenital adrenal hyperplasia is the one which is going to be the right answer, because 10 years old boy or girl with congenital adrenal hyperplasia will be tall, although bone age will be significantly advanced, but for the age they will be tall. 45XU karyotype is your Turner syndrome, and Turner syndromes are short, and so is the constitutional delay of growth and genetic short stature. So the correct answer will be congenital adrenal hyperplasia. Next question is, Graves' disease occurs as a result of autonomous overproduction of hormone by thyroid gland, excess production of thyrotropin releasing hormone in hypothalamus, excessive production of thyroid stimulating hormone in the pituitary, overproduction of thyroid hormone by thyroid gland in response to the autoantibodies, tumor necrosis factor. Well, if you just look at that, the first one, this is the one the people make biggest mistake, because they don't read the question all the way. Because in Graves' disease, you do have autonomous production of thyroid hormone by thyroid gland. And so many of the time they answer that and they don't even read through. But you see, the better answer is overproduction of the hormone by thyroid gland in response to what? Thyroid autoantibodies. Isn't that the Graves' disease is all about thyroid stimulating immunoglobulin or thyroid stimulating antibody? And that's the one drives the thyroid. So I want you to be very careful that read the question all the way. If you see that, well, I think I have an answer, go all the way and then you will find the answer. The very first sign of pubertal development in boy, there will be one answer. Is it appearance of axillary hair? Is it the penile growth? Is it the enlargement of testes? Is it the peak height velocity? Or pubic hair development, adenarche, pubarche? The answer is enlargement of the testes. This is uniform, and the testis size, usually 4 to 6 ml, suggests the beginning of the puberty. And so appearance of puberty and the growth velocity is after the fact. So it is the enlargement of the testis is the first sign of puberty in boy, and this is a very favorite board question. The next question is, all of the following are typically characteristic of Turner syndrome except, see, all of the following are typically characteristic of Turner syndrome. Only one answer is not the right. Is it peripheral edema in neonatal period, normal female genitalia at birth, absence of pubic hair at the time of puberty, associated with congenital heart disease, and short fourth metacarpus on the X-ray of the hand and the wrist? Well, you know that there will be further discussion, and I did talk about a case discussion on Turner syndrome, and if you go and you will see that answer, you will find very easily. Peripheral edema in the newborn period is a characteristic finding, and it does not happen in all cases, but it presents in a female baby. Turner syndrome must be excluded. And normal female genitalia at the birth, is absolutely true, because they are completely normal female genitalia they born with. And the absence of pubic hair at the puberty, that the answer is not the correct one, because remember the puberty, breast development, all this at puberty, breast development is related to FSH, LH, estrogen. However, pubic hair development is female is related to the adrenal androgen, mostly of adrenal androgen. And so therefore there will be pubic hair. And this is called adrenarche, and that is present in Turner syndrome. And so the right answer is absence of pubic hair at puberty, and that will be there. And congenital heart disease, we know, is mostly the coarctation of aorta or bicuspid aortic valve. And the most of the common mistake that do is this one. They say, oh, this is not, although this is not common, but this is one of the finding of short pulse metacarpals in X-ray of the right hand. The other one that you will have to be careful that people get confused with pseudo hypoparathyroidism. Pseudo hypoparathyroidism, the classical form, also present with short fourth metacarpus, but it also can happen in Turner syndrome. Next question is congenital hypothyroidism is most commonly due to secondary hypothyroidism, thyroid dysgenesis, maternal antibody transfer to fetus, inborn error of metabolism, vascular insult to the thyroid gland. Well, the most common cause of congenital hypothyroidism is thyroid dysgenesis. Thyroid dysgenesis includes is ectopic thyroid, and you can have hemithyroid, total absence of thyroid, but mostly is ectopic thyroid is most common. But all those are under the same umbrella of thyroid dysgenesis. Maternal antibody and transfer to the fetus, that can happen if there is blocking antibodies, and if the mother has severe Hashimoto's thyroiditis, and some of the blocking antibodies may go and transiently make the baby hypothyroid, but that is very uncommon. An inborn error of the metabolism, it could be like a organification defect if it involves the thyroid gland, but inborn error of thyroid hormone metabolism is usually the organification defect that only occurs about 10% of the time, and vascular insult of thyroid is not the right answer. Now this question, let's read carefully. A 2-year-old child seen in your in the clinic seen for failure to grow. Clinically, he present with a height below 5th percentile and a protuberant abdomen with hepatosplenomegaly. Laboratory studies obtained at 8 o'clock in the morning shows has a very low blood sugar. Blood glucose is only 21 milligram per dl, and the ketone is 4 plus in the urine, and all of the following abnormalities could give this lab result, except, so one is outlier, growth hormone deficiency. When I will give my talk about hypoglycemia, I will explain this one is a little bit more, but growth hormone deficiency is the endocrine cause of hypoglycemia, and it can present with ketone in the urine and the growth failure. Hypercortisol, low cortisol will also give hypoglycemia and also may present with ketone in the urine. G6PD deficiency is also a cause of hypoglycemia, but they should not have any protuberant abdomen, hepatosplenomegaly, but they can have ketone in the urine. Prolonged fasting, well, that is known to be ketotic hypoglycemia. Ketotic, that means if we don't eat for longer period of time, what do we do? We use our fat. So prolonged fasting is going to give the ketone in the urine. The right answer is hyperinsulinemia or hyperinsulinism. Do remember this one because presence of ketone in the face of hypoglycemia exclude hyperinsulinemia. And hyperinsulinic babies or even the toddler or the infant, they are large for gestation in the beginning if it is congenital. Otherwise, they tend to also be overweight and they are big babies. And the insulin suppresses the ketone production. And therefore, this is important. Do remember this one. The hyperinsulinemia does not present with ketone. And this will be again discussed in details in my lecture of pediatric hypoglycemia. Let's go to the next one. If a 5-year-old boy is referred to you for the sign of precocious puberty, on the physical examination, he is 95th percentile in height, and genital examination shows pubic hair is stage 3 pubic hair with phallus measuring 10 centimeter in length. The testis is present in the scrotum and is about 2 ml by volume. So which of the following diagnoses would be considered? First one is idiopathic central precocious puberty. Idiopathic central precocious puberty, the hallmark is enlargement of testicle. So idiopathic central precocious puberty is exactly like normal pubertal development except that it is coming early. And so this testis 2 ml is a prepubertal testicle. So everything else looks like puberty. However, testicular volume is not coinciding with the diagnosis. Or precocious puberty associated with hypothyroidism. The hypothyroidism occasionally you can see the pseudo puberty, but if it happens in boys, there is a enlargement of the testicle. So there will be large testes. Organic brain lesion. Organic brain lesion will give mostly the central precocious puberty, and that will associate it with normal testicular volume corresponding with puberty, like 6, 8, 10, 12, etc. Testicular tumor, and that is usually unilateral, and there one testis will be bigger than the other, and that certainly does not fit with the description of the case. So the answer is congenital adrenal hyperplasia. This is a very favorite question. The congenital and adrenal hyperplasia, especially if they are partial, if they are poorly treated, and they will have the phallus size for 10 centimeter is a pivotal phallus size, but the hallmark, the clinical hallmark will be small testicle. So if you see the precocious puberty like picture, but the testis is prepubertal, then it is not central precocious puberty. More than likely, it is congenital adrenal hyperplasia. And the beginning of the puberty is 4 to 6 ml of testicular volume. The typical glucose and electrolyte profile observed in a patient with DKA. Number one is blood glucose above 400 milligram, sodium 150, potassium 3.0, chloride 115, and CO2 of 15 mmol per liter. Blood glucose above 400, sodium 132, potassium 5.0, chloride 100, and CO2 less than 10. Blood glucose, next is blood glucose above 200, sodium 142, potassium 3.2, chloride 102, and CO2 of 19. And the blood glucose above 1000, sodium 150, potassium 3.9, chloride 115, and CO2 of 18. Well, all of them has high blood sugar, but let's see the first one, blood glucose above 400. Usually in typical insulin dependent or diabetes with DKA will have pseudo hyponatremia. So 150 sodium level does not go along with the diagnosis. It can only happen if the dehydration is severe. Potassium is high because extracellular potassium is high, although intracellular potassium is significantly deficient. And chloride 115. So the first one does not seem to be very appropriate. But the second one, let's look at that blood sugar more than 400, sodium 132, potassium is high, sodium is little on the low side, chloride 110, and CO2 of less than 10. So that should be the typical picture, and that will be the right answer. The other one has got just 200 blood sugar, CO2 of 19 even does not qualify for the definition of DKA. And the last one is blood sugar more than 1000, sodium 150, potassium 3.9, chloride 115, CO2 of 18. This could be a picture of hyperosmolar hyperglycemia with mild elevation of sodium, but sodium level is hyperosmolar hyperglycemia is usually high because of severe dehydration. And so the answer is the second one. Now, the incidence of type 1 diabetes mellitus is approximately, if you have listened to my lecture, and I have said that there are few areas that they might ask about the incident. One is going to be type 1 diabetes, but they may not ask this question, but I just put it here anyway. There is a formula that you can remember, and I will remind you that again. So 1 in 100, 1 in 400, 1 in 1000, 1000, 10,000, or 20,000. The right answer is around 1 in 400. Around 1 in 400. A 8-year-old boy present in the emergency room with the history of polyuria, polydipsia, weight loss of more than 10 pounds. Initial blood glucose in the emergency room is 700 milligram per dl. What percent of beta cell is destroyed in this patient? Is it about 25, 50, 60, or above 80%? It is above 80%. So by the time they present with this picture, the probably 90% or more beta cell is gone, but so above 80% will be the right answer. Which of the following are usually associated with low birth weight for gestational age? Okay, is it Russell-Silver syndrome, congenital rubella syndrome, maternal smoking during pregnancy, and congenital hypothyroidism? Russell-Silver syndrome or Silver-Russell syndrome, they are small for death, intrauterine growth retardation, and they have a triangular face and hemihypertrophy. So one of the most common and important finding for Russell-Silver syndrome is a small stature. short stature, and they are also also underweight. So that is not the answer. Congenital rubella syndrome, these babies are small. Maternal smoking also cause the low birth weight infant. Congenital hypothyroidism, the baby's birth weight, and actually the baby will look completely normal. So the correct answer is congenital hypothyroidism. The upper and lower segment ratio in term babies is 2.1, 1.7, 1.1 or 1.5. The correct answer is 1.7. The testicular growth at adolescent is primarily due to the increased size of the seminiferous tubules, testicular vascularity, testicular stromal elements, or size of the Leydig cell. Remember that 70 to 80% of testicular weight come from seminiferous tubules. So the first one is the right answer. It is the size of the seminiferous tubules as the patient approaches puberty or adolescent, and that's what contribute most to the weight of the testicle. The exogenous androgen and estrogen administration, congenital adrenal hyperplasia, hypothyroidism, and precocious puberty. I think you should get the answer pretty easily. Estrogen, androgen, they advance the bone age. Congenital adrenal hyperplasia, significant advancement of the bone age. Even well-treated patient will also somewhat advance bone age. Precocious puberty definitely will have advanced bone age. So the right answer is hypothyroidism will have delayed bone age. McCune-Albright syndrome is the combination of which three? Is it virilization, Paget disease, and abnormal pigmentation of the lips? Is it sexual precocity, polyostotic fibrous dysplasia, and cafe au lait spot? Or sexual precocity, osteomalacia, and cutaneous pigmentation, sexual precocity, pituitary tumor, and anosmia? Well, this is a favorite board question, and remember the way the triple P. P is precocious puberty, P is polyostotic fibrous dysplasia, and another P is pigmentation of the skin, which we call cafe au lait spot. And in my lecture of peripheral precocious puberty, I have good pictures of both cafe au lait spot as well as polyostotic fibrous changes, and I have submitted a skull x-ray, base of the skull x-ray. So please look into that, and that will make your conception much clearer. So now the answer is the second one. Next question is thyroid hormone with most potent metabolic effect on the target tissue is T4, T3, reverse T3, DIT or MIT. This is a very easy question. You know that T3 is the most potent because that's the real hormone. T4 kind of pro hormone. So T4 converted to T3 before it do the thyroid activities. Oral contraceptive pills may affect the thyroid test by raising what? So if somebody is taking oral contraceptive pills and if you do the thyroid function test, what you may see, not 100%, but if frequently what you may see, could it be serum total T4 elevated, TSI is elevated, serum free T4 elevated, or it has absolutely no effect on thyroid test. Before, when we did not know how to do the free T4, that's a long time ago, this was a frequent confusion because we know the contraceptive pill increases the thyroxine binding globulin, TBZ, and that TBZ is the one where the T4 is attached. So if the TBZ level is high, then the total T4 will be high. TSH will be normal. However, if you do serum pre T4, that will be normal. So it is total T4, serum total T4, not the free one. The single most sensitive test to detect primary thyroid failure is the measurement of which one? Serum T4, free T4, TSH, T3, or random cholesterol level. And this is also a very easy question. As you know that for a screening of thyroid in adult medicine, internal medicine, they do serum TSH first. If that's elevated, then they do the other thing. So it is serum TSH is the most sensitive and early indicator of hypothyroidism. The incidence of congenital hypothyroidism is approximately 1 in 400, 1,000, 4,000, 10,000, or 16,000. Remember, I told that there is a little formula. Insulin dependent diabetes insipidus is 1 in 400, and incidence of congenital hypothyroidism approximately 1 in 4,000, and congenital adrenal hyperplasia is around 1 in 14,000. Nobody is going to bother with that, but 400 and 4,000, these are the two. Occasionally they might ask you, but you can remember that one easily. Now, let's do some matching this time. DiGeorge syndrome, Williams syndrome, Prader-Willi syndrome, Kalman syndrome, and McQueen-Albright syndrome. Okay, let's see the hypogonadism with anosmia. That will be your Kalman syndrome, because in Kalman syndrome there is involvement, absence of the olfactory bulb or olfactory lobe dysplasia, so you don't smell, because olfactory lobe, where is your sense of smell. Cafe au lait spot lesion with precocious puberty, and that will be your McQueen-Albright. Hypoparathyroidism, that will be your DiGeorge syndrome. The DiGeorge syndrome is also associated with the parathyroid problem, and as a result of that, the patient may have hypothyroidism, absence thymus. And then we have Elfin-Fess with neonatal hypercalcemia, and that is your Williams syndrome. The Williams syndrome, they have the Elfin-Fess, and the cardiac defect is supravalvular aortic stenosis, and hypercalcemia, which is usually present in the first year of life, but it may disappear. And at the same time, they have also growth failure and other features. And these will be discussed when we talk about hyper and hypocalcemia. And neonatal hypotonia is your Prader-Willi syndrome. Although they voracious become very fat, but the neonatal newborn period, they have hypotonia. All of the following is not, which of the following is not a side effect of prolonged glucocorticoid administration? Is it excessive weight gain, osteoporosis, hypotension, linear growth retardation, hyperglycemia? all of them, excepting hypotension. Because the steroid, if you give a long time, they gain too much weight, and there is obviously withdrawal of calcium from the bone, osteoporosis, and the growth retardation with the steroid well known, and also it might increase sugar, so hyperglycemia, by increasing the gluconeogenesis. So hypotension is not a side effect. Which of these chronic congenital adrenal hyperplasia associated with virilization and hypertension? Please pay attention to this question because this is a very favorite board question. CAH associated with virilization and hypertension. Is it 21 hydroxylase deficiency? Is 11 hydroxylase deficiency? Is it 3 beta hydroxysteroid dehydrogenase deficiency, or 17 alpha hydroxylase deficiency? The only answer here, and that's the only one they like to hear, is the 11 hydroxylase deficiency. And 11 hydroxylase deficiency is associated with virilization and hypertension. So when you get a case where they are talking about the virilization, abnormal growth velocity, pay attention to the blood pressure. If the blood pressure is elevated, that's for pediatric purpose, pediatric board examination purpose. That's your 11 hydroxylase deficiency. Absence of ketone is the hallmark of which type of hypoglycemia? And I already told you that, but this is a repeat question. Ketotic hypoglycemia, obviously they will have ketone, and the answer is hyperinsulinism, and this we have discussed before. Again, this question you should not miss anymore. And many more board question explanation and the answer like this will be submitted in the form after the many other lectures, and I plan to submit at least more than 100 board question with x-rays and the case discussion. Okay? And thank you very much.